Thank you, Vijay, for giving a topic which is not being discussed in the textbooks. Of course, we had a lot of evidences coming after the COVID. We used a lot of dexamethasone in people. So people had experience in how to control the blood sugar when you use the very high dose of steroids. We'll see a true case of mine. I always present cases with the case-based presentation on steroid-induced hyperglycemia. First, you should know the difference between the steroid-induced hyperglycemia versus steroid-induced diabetes. When I say steroid-induced hyperglycemia, it refers to elevated blood sugar in individuals who already have diabetes. So here you have to modify the regimen, escalate the treatment. It potentially worsens the glycemic control. Whereas steroid-induced diabetes, on the other hand, describes the development of new onset of diabetes in individuals who did not have diabetes before starting the steroid therapy. Very unfortunate, you give steroids for some time, the patient becomes permanently diabetics. Let me start with the case. I think I need your answers while we discuss the case presentation. Mr. Krishnan is a 55-year-old man with diabetes and bronchial asthma. He was diagnosed with type 2 diabetes at the age of 48. At the time, he was obese, weighing 108 kg, and he was 5 feet and 10 inches. BMI was 32.6. Krishnan lost 7 kg with a very strict diet and daily exercise. He was started on metformin initially, which was titrated up to 1 gram twice daily. But the A1C remained at 8.2 after metformin. So the doctor started him on sitagliptin 100 milligrams and dapagliflozin 10 milligrams along with metformin. The A1C reduced to 6.6 and he also lost about 3.5 kg. Krishnan controls his asthma with inhaled medications, including fluticasone propionate and the salmeterol inhalation of 250 and 50 micrograms. In addition to inhaled medications, now he recently requires prednisolone, 20 milligrams daily to control his asthma. Now exercise become less regular. He also gained about 10 kilograms of weight now. The A1C has risen from 8.5 corresponding to an overall increase of about 280 milligrams after he started on the 20 mg of prednisolone. That was his presentation. As you could see here, even the creatinine slightly started rising, 1.2, microalbumin was present, and he already started developing a background retinopathy. As you could see, his A1C is 8.5, average sugar is 280, fasting is normal, 94 to 135. And the post-breakfast is quite high, 250 to 340. Pre-lunch is 200 to 300. Post-lunch is 220 to 310. Pre-dinner is 125 to 180. And at bedtime, it is 164 to 234. If you could see the lowest level of blood sugar is only the fasting. All other levels are pretty high. Now the compliance of the meal plan is very less compliant because he's taking steroids. His appetite has increased. He started eating. He's not listening to us. And exercise became very poor because his asthma gets worsened after the exercise. Very limited activity. So the current medications, now metformin, sitagliptin, DAPA continued. Is now added on the prednisolone to 40 milligrams. From 20, it became 40 milligrams now. His situation worsened in addition to the inhaled corticosteroids. He's also on the montelukast sodium. What treatment could make to improve his glucose levels? Can I have the opinion fast? 2 minutes time. I gave the situations, I gave the A1C, I gave the insulin. Nothing before insulin? How is it possible? He's on 40 milligrams, he's already eating. Insulin. Then I'll ask you what insulin? That becomes difficult, isn't it? Any other options before we... Okay, we'll see what I gave. Try to reduce the carbohydrate in the diet, and we started doing some exercise, at least some exercise after breakfast, and we also did a diabetic drug modifications. All the three we started. Reducing the carbohydrate, little exercise after breakfast to bring down the postprandial blood sugar levels, and diabetic drug modifications. Reduced carbohydrate content of the meals and exercise after breakfast definitely improves the glycemia. Glucocorticoids like prednisolone have the greatest impact on the postprandial glucose excursions, yielding peak glucose levels after breakfast. Carbohydrates have the greatest effect on the postprandial glucose levels. By morning, the fasting sugar levels of Mr. Krishnan is normal. So the patient's lowest blood glucose levels are in the fasting, and all the other postprandial levels are high. Now, reducing breakfast carbohydrates and exercising after breakfast both may help to reduce the post-breakfast glucose excursions what this patient is experiencing. Depending on his schedule, he can exercise before or after exercise. But sometimes the asthma gets worsened if you do exercise. We call exercise-induced asthma. Sometimes very difficult. Sometimes very difficult to walk after the breakfast. Exercise increases insulin sensitivity, and the effect lasts for several hours. I think you can all try. It can reduce almost 40 milligrams of PP sugar. Or if you have diabetes, you try to do exercise after the breakfast, it will reduce the blood sugar. After consulting a registered dietitian, he reduced his breakfast carbohydrates by eating less cereal and reducing the quantities of milk and juice. We also advised him to try exercising after breakfast to reduce the high blood sugar levels he has been having between the breakfast and lunch and between lunch and dinner. Krishnan could not do much exercise because of asthma. Now, would you like to change his blood glucose medications? Obviously, his answer is yes. Now, what are the medicines you will consider apart from now metformin, Januvia, and the dapagliflozin? Options I given you. Kindly choose the option quickly and then tell me. A. Add an alpha-glucosidase inhibitor before breakfast, before lunch, before dinner to bring down the postprandial blood sugar. Add a sulfonylurea, which really acts very well to bring down the blood sugar. Add a long-acting basal insulin, which will look after the insulin levels all the time, 24 hours. Add pioglitazone, one of the very good insulin sensitizer, because corticosteroids also decreases insulin sensitivity. Add premixed insulin before breakfast. Add GLP-1. Add 3 times prandial insulin, pre-breakfast, pre-lunch, pre-dinner. I want a quick answer from the floor. I given all the options available. One answer, kindly come to the mic and please. If so, why? Come to the mic. Mic, please.
Sir, I want to go with C and F because first I want to have his beta cell, I want to preserve it. So I want to go with C. And regarding...
You want to go with?
C, basal insulin, sir. And I want to add F also because...
What is the action of basal insulin?
Insulin, peakless action.
Already the fellow's fasting is low. He is not very high. I specifically mentioned 3 times. His fasting sugar is the lowest one. He's got postprandial sugar elevations.
Got it, sir.
Would you consider basal insulin?
Then...
Please come to the mic. One of you, please come to the mic and answer. I'll be very happy to discuss his case. Very interesting case.
Alpha glucosidase inhibitors and GLP-1.
Oh, chairman.
Alpha glucosidase inhibitor and GLP-1.
Very weak fellow, no? Alpha.
Sir.
Suppose you want to give this guy 3 times alpha glucosidase, it may reduce to 30 milligrams of blood glucose. 3 times brief breakfast, brief lunch. And so much of gastric intolerance, it will not bring down the A1C. A1C it will bring down, it's got 8.6, it may bring down by another 0.3, 8.3.
I can go for F, sir. GLP-1 act.
Yeah, GLP-1 is a good choice because it is increases in base. They act on the postprandial blood sugar levels. Only thing to make the fellow to accept for GLP-1, that time it was expensive, very, very expensive drug, GLP-1. Takes some time to act. G, prandial insulin. If you are you will take 3 times insulin, huh? Pre-breakfast, pre-lunch, pre-dinner. All the time he requires insulin. K, where is K? A and D. Pioglitazone. Oh. What is the mechanism by which glucocorticoids rises the blood sugar levels? There are many actions. It actually makes the beta cells to secrete more insulin. It blunts the insulin sensitivity. I don't think pioglitazone will antagonize all the effects of steroids. Will it? It takes 4 weeks to act. By the time the patient will die. Okay, we'll give the answer. Yes? I will say I'll go for a premix insulin before breakfast is ideal. I'll tell you why the reason. An alternate choice may be a prandial insulin. Maybe the patient is willing 3 times a day. GLP-1 is a good option, only thing that's expensive. Now probably the price has come down. I could have definitely, because he's obese, 1 shot of GLP-1 with metformin could have definitely, liraglutide 1.8 could have brought down the postprandial blood sugar. But he's already on DPP-4. So I can't give a GLP-1 injection to this guy. Then again I have to shift him to a sulfonylurea, then go in for a GLP-1. Higher dose of corticosteroids generally require insulin. That is number 1, rule number 1. Premix insulins at breakfast is an early, easy and effective way to manage this. Premix insulin contains 3 different types, 25, 75, 50, 50, 30, 70. Depending on the breakfast load he takes, we can choose the premix insulins. The rapid acting component addresses the postprandial sugar, and the one which is NPH looks after the blood sugar for another 7 to 8 hours. Since Krishna's highest blood glucose levels are from the morning to midday, 50-50 mix with a relatively more short-acting insulin was preferred. He is a Brahmin guy, so he eats a lot of more vegetables, more carbohydrate. So actually 50-50 came only for the people who take brunch. They take both breakfast and lunch together, the premix insulins. It's India's concept. The effect of the premix insulins diminishes by evening, as does the effect of prednisolone. Very interesting slide. Actually, see the slide here. The action of the prednisolone and the action of the premix insulin, the curves look so similar. So next time when you use guy prednisolone in the morning, depending on the dose, 20, 40 milligrams, you can uptitrate the guy. Because both effects weans off by evening, 5 o'clock. 5 o'clock, both steroid effect goes away, your insulin effects goes away. What will happen if I give sulfonylurea to this guy? What could happen? Suppose I stop DPP-4, I give sulfonylurea plus premix insulin. You'll go for hypoglycemia because they are longest acting drugs. They act both on fasting and postprandial sugar. They act on all the 24 hours. The patient will still again start eating more, he'll again put on a lot of weight. So the ideal option here, a prudent choice of premix insulins. We started with 15 units of premix insulins. We told him how to uptitrate with the post-breakfast and post-lunch levels. Long-acting insulin, I said, is contraindicated, not at all accepted here because it reduces the fasting blood sugar. His fasting blood sugar is normal. GLP-1 in steroid-induced diabetes, a very useful drug in managing steroid-induced diabetes by improving insulin secretion, suppressing glucagon and potentially reducing glucocorticoid-induced insulin resistance. They are particularly beneficial as an add-on therapy to other treatments when the blood sugar levels are not adequately controlled. Of course, we not combined with the DPP-4. Again, the problem, this guy is already on Januvia. Pioglitazone, no choice at all. It's effective in reducing blood glucose levels in most patients with type 2 diabetes, but not in patients who are using steroids. Not useful. While pioglitazone have been viewed as a safe and effective in most patients, this guy is already obese guy. He's going to have a lot of water retention and CVD risk is high. With diabetes and obesity, elevated blood pressure and lipid excretion is at least an increased risk of cardiovascular disease. Alpha glucosidase inhibitors, chairman, they delay the entry of carbohydrates, but they may be adequate to, if you're taking 5 milligrams, maybe. If you're taking 5 milligrams of corticosteroids, you can try a very small dose of DPP-4, you can say try a small dose of acarbose. 30 to 40 milligrams, it may be able to reduce it. But generally not effective when the patient is taking a dose of 40 milligrams. Now after 2 weeks, he's on premixed insulins, 50, 18 units. We know still the postprandial levels are high, 215, 291 post-breakfast, 185, 282 post-lunch. At bedtime, 162, 225. We uptitrated from 18 to 22 units. Now after 2 weeks, now you look at his blood sugar levels. He still has some postprandial hyperglycemia in the mid-morning and the bedtime. Now what will you do in this case? Because the limitations of the premixed insulins, we can't, because they are fixed 30, 50, 25. We can adjust the dose. So the situation has arisen like this. Now how will you adjust or modify the regimen, insulin regimen in this guy? Yeah, one choice is definitely again a prandial insulin, but patient will say, sir, you need one more prick. You give a premix and also a small dose of prandial insulin twice a day, pre-breakfast and pre-lunch. Anything else can be done? We do it. I think Sundaram should be doing because the very technique used those days. We count the carbohydrate, how much he is taking, how much calories you require to bring down the. So you take the short-acting component separate, we take the NPH separate, which can be mixed in a single syringe. It's called split mix therapy, one of the very, very old regimen, but still very useful in this case because he can modify the post-breakfast, the excursion of the sugar by modifying his regular insulin. So an evening injection of premixed insulin is not advised here because his fasting sugar is quite normal. And evening dose of premixed insulin rises the fix of nocturnal hypoglycemia. So the options here are given: add regular insulin before breakfast and dinner, add a long-acting insulin like Clargin, again, GLP-1. I think regular insulin will be an ideal choice here in case the patient cannot mix the insulin properly. Adding regular insulin before breakfast and dinner will address the late morning and bedtime hyperglycemia. However, if the patient continues to use premixed insulin before breakfast, you would need to inject a second dose of regular only insulin. An alternate is to teach the split mix therapy, how to draw the custom mix NPH and regular into insulin syringe. I think one of the old techniques, very forgotten technique, but still it was very useful in this guy. So when you come to the discussions, the patient and the physician discuss the two first medication options. They decide to use NPH and regular insulin vials and the insulin syringe to mix the custom ratio. This situation illustrates the premixed insulin's limitations, because the prandial component cannot be adjusted more than 25, 50, and 30. So we use this guy a split mix therapy. And we asked him to come when he reduces his dose of steroids, how to also de-escalate the dose of insulin. Now, it's quite okay. Now, after some time, this patient is on 14 units of regular insulin and 15 units of NPH insulin. Look at this, and 6 units of regular insulin at bedtime. Look at the sugar levels. Almost has come to near normal. He's doing very well. What about sulfonylurea in this case? Suppose you want to decide on using sulfonylurea, what sulfonylurea will be better in this guy? Suppose somebody is using 5 milligrams of prednisolone in the morning, 10 milligrams of prednisolone in the morning. Somebody using 15 mg of prednisolone in the morning. He doesn't want to use insulin. SU and premix insulin kindly avoid in your practice because they can cause glucose glycemic excursions, lot of hypoglycemia, defensive snacking, they put on a lot of weight. The once daily glycoside, I've seen in my practice very, very good. Excellent in guys who are taking a short time steroids, especially in the hospital. We start the patients on some indications for a few days. What we do is once daily glycoside to start with 40 milligrams before breakfast. We can up-titrate up to 240 milligrams, depending on how much checking on the post-breakfast, post-lunch levels. Extremely useful, very, very useful. We need not use insulin. Those guys, the sugar level will come down. Check the post-breakfast and post-lunch sugar levels. We can add another 80 milligrams pre-dinner also. Very short-acting drug. They don't go for fasting hypoglycemia. The maximum dose of glycoside in steroid-induced diabetes is 320 milligrams we can use. Of course, the people may ask what is the sustainability of glycoside in the condition. It is good. Generally considered good, particularly when used in conjunction with insulin or other therapies. While glycoside can be effectively manage the initial hyperglycemia and postprandial glucose spikes, cause steroids, the long-term susceptibility and effectiveness can vary from patient to patient. DPP-4s are a good drugs of choice and patients taking a very, very mild dose of steroids, up to 5 to 10 milligrams. It can bring down the blood sugar postprandial by 50 milligrams to the maximum. So you can also use in your practice when you're using a small dose of steroids. One of the very important questions, you start patients on insulin, steroids, do all become diabetics? Many people find their blood sugar levels return to normal, healthy range when they stop the steroids. But others, steroid-induced diabetes can continue even after we have stopped treatment with steroids. This is more likely if the patient is a high risk of type 2 diabetes. Very unfortunate, the patient has a family history, he is prone for type 2 diabetes. Those days, we've been taught to do a steroid test for diabetes. We give 40 milligrams 48 hours before. Check the 2 consecutive day fasting blood sugar levels. Whenever there's a 40 milligram rise in the fasting sugar, then we know that he's going to become a diabetic. I think one of the obsolete and meaningless tests. These are the equivalent doses. Remember in your practice, hydrocortisone 20 milligrams is equal to prednisolone 5 milligrams, which is equal to methylprednisolone 4 milligrams. Dexa is 0.75. Beta is 0.5 milligrams. So normally use 2 milligrams of dexamethasone. Imagine how much is relates to the prednisolone. When you remember these drugs, the methylprednisolone and the dexamethasone are the highly diabetogenic drugs. Methylprednisolone and dexamethasone. In your practice, when you use, most of them will require therapy to bring down the blood sugar in some way. Of course, the slide was given by Vijay. Hey, Vijay, you all given all the oral, inhaled. Arjuna, your father told about you very much in the morning. We are all nice to hear it. So you can see intradermal. But topical steroids also can cause diabetes, especially the very potent steroids. Sometimes people use it for psoriasis, for long-term events. So some of the steroids also when you use it, especially children, you should use a very soft steroid, not the very strong steroid. Is there a safe steroid? If you could ask me, I will say there is a safe steroid. Probably the safe steroid is deflacort. Is sometimes considered less diabetogenic. More diabetogenic is methylprednisolone and dexamethasone. Less diabetogenic is deflacort. If you want to really use it, it is available as syrup, drops, tablets. For asthmatics, you can use it. Methylprednisolone and dexamethasone are the most powerful diabetogenic steroids. These are the actions of the steroids. When you use hydrocortisone, the peaking. as per the peaking, you should give your therapy to, when you see the dexamethasone, the long one, it acts for all the 24 hours to 36 hours, the longest acting steroid. The triple insult by the dexamethasone in COVID. The COVID has really taught us how to, we all gave, after 1 year, the standard treatment of COVID infection is dexamethasone 6 milligrams. 6 milligrams. But some studies also gave 12 mg of dexamethasone. Then people who know that, when they use NPH insulin twice a day, they found the effect was so good. It is effective in controlling the dexamethasone. Of course, the ideal way is to give a basal bolus therapy. But all our patients are not very rich enough to have an analog basal bolus therapy. The ideal will be when a patient is on long-term dexamethasone in the ward. Please give them NPH insulin twice a day. So I think the last but one slide. Steroid-induced diabetes treatment generally involves a multi-pronged approach, not given in any textbooks. This topic is not discussed in textbooks. How do you select a topic not given in textbooks? Including blood glucose monitoring, lifestyle adjustments, potential medications like insulin and oral anti-diabetic agents. The specific treatment plan depends on individual's situation, the severity of the hyperglycemia, and the duration of steroid use. Thank you. Thank you very much.